Sorry for the slightly late start, ladies and gents, and thanks very much for coming. As you might not know, but allow me to remind you, this is a seminar within the series of impact case seminars that we're doing, and to remind staff about the importance of research impact for the forthcoming REF. Now a higher proportion of the total score than it was in 2014. But those of you who've taken the time to look at the school's mission statement recently will have seen that apart from doing well in research terms, which of course we must, the school is also committed to doing good, and it committed itself to that even before research impact was a thing that was measured formally by the REF. It is implicitly important that an organisation like this contributes to the public health. So I'm delighted to introduce Miriam Taegtmeyer, who I've known for rather more years than either of us is likely to admit to. And Miriam heads the Community Health Systems Research Group here at the school. It focuses on implementation research, and particularly research that bridges between different disciplines. So let me hand over to Miriam now, and I'll take... Okay, keep talking. Oh Lord, I could do a song and dance at this point, I suppose, or tell a joke. Are we not working? Bear with us, technical trouble. Of course, usually when there are technical troubles at a time, large numbers of academics will cluster around the keyboard and press keys at random, achieving very little.
Come on, keep going.
I'm done. It's like piloting the Starship Enterprise here, but hopefully we shall have warp speed momentarily. It all seemed to be on screen a moment ago.
Yeah, I just blacked it.
1 hour ago, no, I did 14, 20. There's one that was a few minutes ago.
Sorry.
Okay, I might as well start without slides, so as to save time. My name is Miriam Taegtmeyer. Thank you very much for coming, and thank you to people who are listening in as well from other places. I am a clinician. So what is a clinician doing in community health systems and universal health coverage, which is the topic of our talk today? And for me, the journey started in Kenya about 20 years ago, where the initial concept that I was sent out to work on was to decentralize HIV services from Kenyatta National Referral Hospital and other referral hospitals which were filling up with people with advanced HIV disease, 92% of medical admissions, 73% of surgical admissions, to provide HIV care in the pre-ART era at primary health centre level. So all guns blazing, okay, trained clinical officers, x-rays, blah, 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 and nobody came. And nobody came because nobody knew their status, because of, yes, stigma was an issue, but actually testing was the main issue. So getting rapid tests to those communities for people to access the services became the focus of the work. And luckily the timing worked really well because there were new diagnostics coming on board in the year 2000. So you could get up, walk to a health facility, and then within an hour or 2 hours at that time, you could have your result and go back. So a huge difference from waiting a week or 2 weeks, which was the previous, and impacted the number of people getting their results massively. So the technology came together at the same time with this decentralization. And people started coming. We started seeing shifts in stigma, and this is pre-ART era, big uptakes of VCT, and we piloted this in the first 3 public government health facilities to provide rapid testing or at all in sub-Saharan Africa. And previously there'd been this study, but it was in standalone sites. And then from there to 33 sites in 4 districts, learning operational lessons from the first 250,000 people to test through rapid testing in Kenya. And then eventually to 2,730 primary healthcare centres providing rapid tests with the 15-minute results. But yet here we were in all these primary health facilities, and there was still a big testing gap. So we started to innovate and think about, okay, outreaches, campaign days. This is a flatbed truck that got pulled around from village to village, and every 3 weeks it would move on. And you can see that there was a big shift in people's sort of willingness to go and stand outside somewhere that said HIV testing offered here. These are queues of people waiting to be served. And you couldn't finish in a day the number of people that were coming forward. So big shifts in the community attitudes towards counselling and testing. But still, there is a big testing gap. So we thought, okay, what about a door-to-door programme? Go door-to-door. And we started doing that, working with communities. How's this going to happen? And the WHO asked me to do an evaluation of the door-to-door programme. And for me, that was a bit of an aha moment, because well, also it was fun, because I got to sit in lots of people's homes in different countries, watching counsellors doing testing in the home. So the community health workers identified the homes, and I got to sit there, and I would sit in polygamous families, in rural areas in different countries, and watching them. And I watched them. Instantly you're sitting there, you see so many things going on. You see like the bed net that has never been opened and is tucked under the bed. You see like that alcoholic partner lying in the corner, not barely engaging in the whole discussion. You see the kids coming home from school, chickens coming in, packing on the kits, all of this. And I got blisters the first 2 days just walking between these houses and thinking what their community health workers are doing. And I realised they have this really unique opportunity. And it took me back to actually medical school, where they said, you know, you're in a hospital, everybody's in a gown, you approach them from one side of the bed, but wait until you see them at home, because you'll understand things differently. And the first GP visit I did, it was in a tower block, and it was the 13th floor, and it was an asthmatic child. And we walked in, and there was like a TV, a sofa, no other furniture, 3 kids eating chips, watching TV, and both parents smoking. And this child not being able to breathe. And you could instantly see some of the things that were happening there. And it took me straight back to there. It's like these community health workers have this unique opportunity to really understand health at the community level. And also HIV test, I'd lived and breathed and actually dreamed about HIV testing for about 5 years at this point. And I realised, HIV testing is just this one tiny bit of life in these homes. And that is really what started my journey into community health equity, and effectiveness and efficiency. I am still a clinician, but I've sort of my sweet spot is where the two of them overlap. And the Community Health Systems Group really reflects some of the learning that I did in that first phase, learning about, yes, you can integrate, learning about, yes, you need to work with ministry, learning about vertical programs can distort health systems, and HIV testing is a very good example of that. So where in antenatal at dispensary level, syphilis testing was going on, hemoglobin testing was going on, HIV money came along, 90% of pregnant women HIV tested, syphilis testing down to 22%, having been very good. Anemia testing down to about 30%, having been near universal. So HIV testing, HIV monies have distorted lower down levels of the health system. And that was also a big learning piece for me during that period. And I brought some of that, I think, forward to the Community Health Systems Group, where we combine disciplines. We have a number of doctoral students as well, and you'll hear a bit more about their work, and a lot of networks in different countries, as well as some qualitative research networks and the thematic working group in close to community providers, which you're welcome to join. It's a virtual community of practice. I've said we have a wide range of networks. They're mostly in Africa, in East and Southern Africa, but also in Southeast Asia and Bangladesh, Indonesia, and the Philippines. And these partnerships are mostly long-established partnerships, between 5 and 20 years, which has really helped us as we engage with community-level and district-level stakeholders through national systems. We currently have a portfolio of these projects, which are a mixture of projects that take forward work in the HIV testing, decentralisation, and work that is looking at community health workers as a platform. And I'm very interested in this space between vertical programs and community health systems. And the projects all do reflect that space and have some common themes that I'll talk to you more about. Our vision as a group, despite disparate projects, is quite cohesive. So our vision is to create a world where your health is not dictated by who you are, where you are born, or where you live. And we conduct research, sort of implementation research on community health systems, engaging with and partnering with communities, with practitioners, and with policymakers, and using research to strengthen or improve high-quality community health systems for underserved communities. So reaching the poorest through and having impact through community health systems. And I always think if it's not happening at the community, it isn't happening, no matter what lovely documents it's in, or how well it's phrased in those, or what high-impact journals it's published in. If it's not happening in the community, it isn't impact. We have a range of approaches in this word cloud, but I would say as a clinician, I was really taught to worship at the altar of the randomized controlled trial. And the experience of community health systems has made me realize that both that you need multiple research methods on this platform, but also that we have to think beyond research methods in combining with implementation to really value those partnerships right from the voices of community members and community health workers. So we shouldn't be asking questions like, what can a community health worker do for HIV, for TB and lung health, for distributing nets, but rather, what are they saying and how can we support them in these platforms? And that requires us to take a bit of a different approach and make sure our research is not extractive, but shares, answers questions that are needed, develops capacity, and takes time. It takes time to do that, to do it slowly and to do it well. So, how do we achieve universal coverage with quality and equity in these very distal parts of the health system and at household level. And it is a question that is more and more in the news. The new Director General at the WHO, very focused on universal health coverage. He's been touring around different countries. A few weeks ago he was in Kenya to ask them how they're doing on universal health coverage. And I heard from colleagues last week at the WHO, he sent around a memo asking each disease-specific department to say what universal health coverage would look like for their disease. And they're having a big collaborative process in the WHO right now to define what they mean by universal health coverage. So it's very timely for us to be thinking about community platforms on the global scale. And universal health coverage really is saying that everyone has access to quality health services that they need without risking financial hardship from paying for them. So there's a need for us to ensure the basic standards of quality of care, to motivate providers and professionals to improve, and to activate patient and public demand for quality. Because if we focus solely on expanding access and we don't address quality issues, then we're not going to have ultimate impact on population health. So great, you can have lots of community health workers reaching lots of households, but if they're not giving the right advice or doing, they're dishing out antibiotics inappropriately, we could actually do harm. And for example, by increasing antimicrobial resistance, because a lot of community health workers are prescribing antibiotics inappropriately, in fact. And this issue of quality and universal health coverage is one of the Sustainable Development Goals. If you see that the word quality is integral to that SDG 3. So quality as a dimension of universal health coverage. We've got to ask ourselves with universal health coverage, what are the sort of 3 areas? So who is being covered and how do we reach these uncovered people? And in HIV testing, that might include hard to reach areas. And in community health, we often think about the remotest or the hardest to reach areas. But it also includes communities that might be living right in the capital city, but for another reason they can't access services, like MSM in a country where it's illegal to be a gay man, or adolescents who feel that the services are not youth-friendly, or men who don't feel unwell. Those could be target populations for extending coverage. And then, as I've said to you just now, the WHO are looking a lot at what services does it mean. And different countries will use community health workers for different things. So a very common one is reproductive health, maternal child health. But what is that basic package? And that has not really been defined. And it's certainly not been defined with the voices of community members or community health workers inputting into that. What do they see as their priorities? It's a work in progress. And then finally, this dimension from the definition about financial protection and people having to pay out of pocket. And in fact, when we've done cost effectiveness work with community health workers, we find that they are paying out of pocket to support their neighbours for referral sites, to go to referrals, to feed their children. And some of these programs using community health workers are actually making the community health workers poorer because they're spending their own money, not feeding their own kids, in order to ensure that their neighbours are able to meet in an emergency. So this issue of financial protection and cost effectiveness of the programs also has a lot of hidden areas. So community health, so universal health coverage, people are like, great, we'll use community health workers. And in Kenya, they have this wide portfolio, and these pictures are all from Kenya, but it's similar in a lot of countries, of tasks that they do in health promotion, in encouraging healthy behaviours, in prevention, and in curative. So they, in Mozambique, for example, they do malaria rapid testing and treat malaria. They treat under 5 pneumonias and dispense antibiotics. So there is a curative care element in some countries more than others. Most are focused on health promotion, health prevention, and basic curative needs like diarrheas and respiratory diseases. And if you do a small study on a project or a program with one disease focus, and you've put in some effort, community health workers can be effective. So they can do adherence counselling for ART, they can do defaulter tracing, they can do preeclampsia screening in pregnant women, they can do sputum collections, they can do ITN distributions, and LSTM, and some of us, we're co-authors on papers that show their effectiveness in those circumstances. They can do what I was describing, door-to-door HIV testing. But then the project goes and they can't do it. Or they can do it, but they can't do the other tasks that they have to do. And they're sitting there juggling all these multiple tasks. And the more tasks you add to them, the more houses they need to go to, the more the quality is compromised, so the less you're achieving UHC. And the more different NGOs come along and ask them, spend a week on this, we've got polio campaign, the more that coordination becomes a problem, because you've got different supervisors, different registers, different data sets, different per diems, different allowances, different trainings. So this coordination of different programs is an issue. And in reality, you know, here are people who finish school, they don't have professional training. Some of them actually can't read and write, we found, although they're meant to be able to. And we're asking them to be the final common pathway of every vertical program in the world, because we all think our thing is the most important at community, and we need to expand universal health coverage. So is that really the solution? And they're volunteers. So when they are trained up, they get a job and they leave. And then you've got to train other people up. And then the quality goes down again. So is it really this panacea to universal health coverage? I'm going to spend the next few minutes going through sort of 3 areas. What we've brought to defining community health systems, some sort of research thoughts, methodological thoughts about researching these complex adaptive systems, and then some of the experiences of the different projects in improving systems. So a little bit on defining, researching, and then some of the projects in the portfolio that are working to improve community health systems. So what have we been thinking about defining community health systems, and what is our work brought to that? I would say the key lesson from all these projects, all these countries over time, is that, and it's so obvious, is that they work at the interface. So they're not in the health system, but they're not fully community members either. This is a conceptual framework of the interface. And what I just want to point out here is that the traditional, what WHO has these building blocks of health systems. I'm sure you're all familiar with them. And in this conceptual framework, we're calling them the hardware issues. But it's things like the people and how they're paid, how the service is delivered, their SOPs. Community health workers very rarely, in fact, have a job description. The information, the data they need to record, the medicines, the kits that they have, the financing structures, the governance structures, within this wider context where health systems policy, practice, and the environment sit. So a lot of people say, okay, that's health systems, and those building blocks are the areas you need to take into account in health systems. And yes, we found they are important in community health systems, but they're only one aspect of the community health systems. And so we do need to redefine health systems work if we add community health in front of it. Because there are these other more subtle, more nuanced complexities about working at that level. So supervision, motivation, performance are all need to be targeted at that interface, because community health workers really feel torn. Are they supervised by the community, which has selected them, which calls them my nurse or my doctor, and who they have to report to? They have to go to meetings, they have to report to, who actually support them financially or in other ways. They might go and dig your field while you're at somebody's house, that kind of thing. Or are they responsible to a supervisor from the health system who comes once every 3 months and goes, no, none of this, you didn't fill this properly, you didn't do that, and ticks some boxes. And they're very torn between those two. And the community is there every day. The health system is there now and again. And when it comes, is not very supportive. And it doesn't understand that, well, I had to do this differently because so-and-so knows so-and-so, and that means this, and I trust this person, and the way women are treated in this community is this way, and I'm part of that, and so if I approach it this way, it might work. So it doesn't take any of that into account, and eventually that tension can get to them at the interface, and that affects self-esteem, it affects motivation, and it affects performance, because they're volunteers. So they're doing this for the good of other people in their community. And gender is part of that. There are a lot of things sort of at that interface that are part of it. And gender we're exploring a bit more together with Sally Theobald and one of the doctoral students, primarily in Mozambique and Ethiopia. Mozambique, where 70% of community health workers are male because of recent civil well, not so distant past civil war and security issues, but policy states it should be mostly women because the package is maternal child health. And in Ethiopia, where the policy states that health extension workers should be 100% women. And how does that play out in relationships within communities? There are a whole load of issues that are raised where caregiving expectations of women, women's volunteerism, women's roles and women's security in the community, what houses they can and can't enter depending on who is there, play out into how they're able to perform their job. So some people will say, I don't want my wife to be a health extension worker because then she'll go to a home where there's a man is home on his own, home alone on his own, that kind of thing. So lots of complex norms, community norms, including gender norms, play into community health worker performance. And this issue of coordination that I've alluded to has also come strongly out of the data, and that the multiple vertical programs can have this very negative, often negative impact on performance. And different incentive structures can lead to serious mistrust at community level. So if Peter comes along one week with a leprosy program, and he's offering me a training where I get a meal and a certificate, and then he's offering me £5 for a day, and I'll work for him. But then afterwards, Beth comes along and she says, okay, we're doing indoor residual spraying this week, and I'm going to offer you £7.50 per day, and the training is one extra day longer. The next time Peter comes along, I won't be that interested. But also, people that Beth picks, and the people that Peter might have picked to do the work, who used to be friends, start to be like, well, why did they get more? So all these issues came out of transcript after transcript after transcript in the qualitative work. And they influence not only those specific 1 week little things, but the bigger program, the people that are actually on the ministry payroll to expand the reach of services in Malawi through the Health Surveillance Assistance Program. Another area that comes up loads is how at the interface, how do you manage referrals? So a lot of their job is about, okay, refer you in for this, go to the health facility for that, do the other. And even more complex in places like urban slums is there are a lot of informal providers. So every little kiosk, every little centre has additional complexity of not being part of any system at all, really, more in part of the community system than part of the health system as such. So tracking referrals, you can keep a record of who was referred, but in virtually none of these countries where we've done research is there good quality data on who got to the facility, what happened, and what they were told back. So they don't learn from doing referrals, but we've also no idea how effective the community health programme is. And finally, the sort of role of the communities themselves it came out as a theme, that they're rarely engaged in a genuine way. And devolution has been one way of trying to address that, decentralising health services and writing into policy that communities should be engaged in decision making, and sort of moving them away from only thinking about the building blocks, the health system's hardware aspects. 2 countries that we work in have strongly devolved health systems. Indonesia is one of them. And that was in part driven by, it's a country made up of thousands of islands, and each island is a district, and it's fairly autonomous. And to have devolved health systems makes geographical sense, as well as thinking that it would improve the equity of services. In Kenya, though, on the other hand, it was a do you remember there was post-election violence in Kenya? And after that, devolution was a sort of an effort to improve health equity, because it was thinking that differences, inequities in health, amongst other things, were part of what was driving tensions. And so devolution, the idea of devolution was to improve health equity through improving universal health coverage. And it was the first time that counties held the entire budget for health. And they make the whole decisions. How much goes to the facilities, how much the nurses earn, how much goes to community health services. So how do we balance preventive versus curative? What about building new infrastructures and all of this? And our findings from 10 counties and hundreds of interviews in Kenya is that, and it's not a big surprise, it's incredibly complicated to make decisions. And the less real data you have on what's happening in the community, the more the influence of power and politics fill that vacuum, and people can use that space, because there's no evidence, to make decisions that benefit them and ultimately don't achieve universal health coverage. So somebody who's maybe going to a village to teach them about latrine use or clean water, it might not be so politically attractive to fund that when compared to funding something very visible that can have a photo in the newspaper. And here's an example of such a theatre space which has never been used, because there's no money for staffing, there's no money for drugs, there's no money for the resources and materials, or power even. We saw the same again and again with ambulances. Buy ambulances, no money to fuel them, nobody to drive them, no need for them, because people in the communities can't ring for the ambulance. So into that space come issues like corruption, patronage, maybe tribal ties, so villages that feel neglected because of political differences, community health systems feeling that the balance of power is wrong. It's not easy to say no. It's difficult to stand up and change things. If you want something from the community, you just pressure them until they come up with a decision. So the ambulance is a good example. may not even be pressure. It may just be that the community don't know what they're balancing up. So there's something very visible. It sounds like a good idea to them. They're like, yeah, ambulance. Okay. So it doesn't have to be overt. And community health workers, they have access to people. They go into people's houses. And as such, politicians see them as a way of winning votes. I could use this community health worker to do a bit of campaigning for me. And that may be direct or it may be indirect. In fact, there's quite a lot of transcripts, both from Indonesia and Kenya, that indicate that no real community health work goes on for 2.5 months before an election. They're just given campaign T-shirts or scarves, headscarves or something, and then they go out. So vote priority is a strong issue in this group. So what we've realised is that defining the community health system requires us to define the software side of it, the ideas, the interests, the relationships, the trust, the power issues, the values, the gender norms. If we don't take those into account when we're designing the community health system, they can't perform because they just leave, because we haven't supported what is most important to them every day. So what about research methods in this complex adaptive system? Complex adaptive systems by nature are not linear. So it's quite difficult to have an intervention, a primary outcome and a secondary outcome, and just that's it, without seeing beyond that. It's insufficient for understanding whether this can impact and have impact at a community level. There are few standards and there are few indicators of what they should be doing, few indicators of quality of community health at the moment. It's very difficult to attribute your intervention to a benefit, and data quality is very poor. It's something like between 17 and 25% of what they do is accurately reported in the layers above. And it changes all the time. So when Peter comes with his program, and then a week later Britta comes along, does something on malaria, and then a little bit later it's something else, then there's multiple iterative changes to what's happening. So it makes it difficult as well. Here is us trying to work out how would supportive supervision training for community health workers improve health in communities. So how can we say this supportive supervision intervention has improved health for these children or these mothers in these communities? And you can see these are just some of the interim steps. And what happens a lot in the research is that you take very proximal measures to try and overcome this issue of the complex adaptive system. So research does require multiple methods, and it does require this prolonged relationship and this prolonged sort of follow-up period where you've really understood context. Otherwise you can't compare across contexts, and you can't advise the WHO on your community health guidelines should say this and that. And where you engage the community health workers and their voices right from the beginning. So you remember I used to worship at the altar of the RCT. Well, I do think RCTs are required. There is some proof of concept needed, but they have to be pragmatic trials. So policymakers will often ask, well, if this is training and it's supporting people, can it be a stepped wedge design? Could you do a stepped wedge cluster randomized design, maybe, so that everybody gets the benefit in the end? But we really have to look beyond the RCT. We really need the social science, we need modelers, we need health economists, we need multiple disciplines working together. And we need to get the buy-in of the stakeholders at national and higher district level very early on. Community health is not something where you can go along with your question, do a lovely complete study, get it into the New England Journal, and then tweet that it's there and expect them to change how things are done. It just not work like that. You really need to plan the partnership with the stakeholders from the beginning and understand from them what is the evidence they need and how they'll use it. And jointly develop methods and data collection and analysis, involving them as co-investigators in studies. And then the dissemination part's easy. In fact, they do it for you. You don't have to do a lot of that if you've done your research uptake from the beginning. And the approach we've really taken in the Community Health Systems group is that we're looking for patterns. Some of you might, clinical probably, and you'll recognize that this is an Ishihara chart. And if you are not colorblind, okay, if you're not colorblind, then you'll see a sort of green helminth-like thing winding its way through this photo. So there are a series of these charts that Ishihara developed. And community health systems research, to me, is like each of these is a rigorous study with its rigorous methods, its originality, its significance. But on its own, it's often one disease or across countries or one country or one project or one method. So it could be a systematic review, it could be an economic study. But until you bring them together, it's quite hard to see the emerging pattern. And that's really how we came to this interface role being very important in defining systems. It was bringing all these studies together and saying this is coming up again and again. So our approach is, come and work with us with all your different methods, help us fill in the Ishihara chart. And we don't have to use red and green, we can use colours that everyone can see. Okay, so we've talked about defining, we've talked about research and complex adaptive systems. I'm going to talk about improving now. And I see improving as either you introduce a new thing, a new diagnostic. I can see Emily's here, thank you. New drugs, new technology. You could change what you're doing, streamline systems, make them more efficient, streamline. Or you could just do what we know works and do it well. So it's not rocket science. It's just getting out there and delivering what we should be doing. And the different projects, each of them are focused on an improvement. So the STAR project, which we're a partner on, is this massive millions of self-test kit being distributed in Southern Africa study. And it lends itself very well to community level because individuals are testing themselves, collecting, performing and interpreting results, linking themselves to care. And available data reviewed by the WHO shows it's very acceptable, they can perform well, it's probably going to be cost effective, and it compares well to other HIV testing. And it's become a WHO recommendation with moderate quality evidence. And in fact, STAR has used community-based distribution agents to get self-test kits out there. But we've been doing that primarily as a vertical program initially. So picking up community-based distribution agents, training them, giving them iPad, giving them a bicycle, having them distribute kits, and then moving on to another area. So very much still in the vertical program mentality initially, community-based rather than community-led. As we transition STAR now to a more community-led model that could be sustainable, we start to have to listen more to policymaker perspectives who feel that it's still largely project-led, that the regulation, the safety and quality of using kits in communities is lagging behind, that there's still silos. So the National Reference Lab, the HIV department, the Community Health department, the regulators, they don't have fora where they regularly meet. They don't realise they're all working on self-testing in parallel, for example. And the same thing happened with antenatal. The HIV department does PMTCT, malaria department does its thing, reproductive health does the anemia, STIs do the STI, and unless malaria control, AIDS control, and Department of Reproductive Health sit together, then you get challenges of these silos within the health system. And they play out at community health level because all of them end up at the community. So any silo that's up there is translated to policies, is translated to stuff, ends up a silo at the bottom. And what the policymakers are concerned about as we transition is how are we going to pay for this? Are people actually going to link to services after self-testing? And are we reaching the people we should be reaching, or are we just replacing something that was working with something else that's more convenient but probably more expensive? So we need to really listen to their concerns and develop regulatory systems that address safety and quality in community levels. And within our group, we have laboratory and regulatory expertise looking at how new diagnostic tests like this can be safely implemented in the hands of users, self-testing, and in the hands of lay people at community level. And we're really working hard to think about transitioning from that vertical getting these out there to how communities can lead and own self-testing. You know, of how they decide who distributes them, they decide when, they decide how linkage will happen, they decide how social harms reporting will happen and where. So early days, and I'll report back on that. We're also introducing new technologies. Some of you have probably downloaded the mobile game, Battle in the Blood. If you look for it on the App Store with that, and have a play, give us any feedback. This is a mobile game that is aiming to improve the uptake of HIV testing amongst MSM, adolescent MSM in the Philippines. So it's improving knowledge, attitudes and linkage to testing and to care. So if you've played and you've got feedback, do contact Charlotte directly. Put your hand up, Charlotte. And otherwise pass on the messages or let us know if you have other contacts, particularly in the Philippines, which is our current target population. It's something that in future could work very well in communities that order HIV self-test kits on the internet. Because you could click onto something at the end and get a self-test kit. Dolphin is looking at a new drug in communities. We need to understand how communities understand new drugs, why they access them. It's an antiretroviral to be used in late pregnancy, a challenge for women to come from communities to that. And the IPOC is more looking not a new technology, but streamlining existing technologies. And here we're taking 4 point-of-care tests at dispensary level in antenatal care in Kenya, and looking at the impact of that on the health system. And if you look at these first two slides, you can see before the integrated platform, only a minority of people are getting syphilis tests, and the large majority here in the darker were not getting. After the integration, lots of people were getting their syphilis rapid test, and in fact their hemoglobin, malaria tests. But no impact afterwards, no difference on the very high uptake of HIV testing pre and post the integration of the platforms. So you can do sensible, innovative streamlining without distorting existing systems. And finally, working on improving what we know works. So SCALE is introducing simple quality assurance and quality improvement methods to community work improvement teams so that they can improve their data, use their data, analyze their data and work on it. And it's been hugely enthusiastically received in Kenya. To me, all this fits in really well at LSTM because it's all about impact. So we have our basic research, we go to human trials, we maybe get it into policy, but if it's not happening in the community, it isn't happening. And like an HIV vaccine, we could develop one here at LSTM, and we could put it into policy, and we could have our phase 1, 2, and 3 trials. But if the community felt like it was going to make them infertile, or it was going to stigmatize them, or they couldn't reach it, it wouldn't happen. So this is very important to us, and we're very open to collaborating, because lots of people are using community health workers in the school for their disease-specific focus. So we'd love to collaborate more across the school, and also to extend the methods to modelling, to a bit more on trials, and to some of these thematic areas that support the sub-themes within our group on quality improvement and stakeholder engagement. So there can't be a panacea, I don't think, because they're never going to be the universal remedy, but they are part of the solution to universal health coverage. And thank you, and I'll leave it there, but thank you very much for listening.
I'll save the rushing around with the microphone to start off with. Health can be quite dynamic. People can be quite conservative. How do you encourage the community workers who may be quite conservative because they know what they're doing and get used to what they're doing to accept that things will change and to be part of that change?
I agree. People come from the societies that they're serving at the same time. So it is a wider listening exercise, and it is this time issue. Often I think we're impatient as researchers, and we have finite funding. So the long-term engagement and the long-term trust is what makes a very big difference at this level, and not expecting to rush things all the time. Like the story with HIV testing and stigma, it took time, it takes years.
Any other questions? Sir.
Sorry, I was late, Miriam. What about funding? So when you have external organisations funding programs that are disease specific, you then have money that's promised to that, sorting that disease out. How, what sort of approach can you take to change that? And are people likely to be receptive to that? Those people giving the money, and I guess accepting it, the governments as well, who are getting money from elsewhere.
Thank you. It's a really good question, and some of our work on economic evaluation speaks to it as well, is that there is a bit of tension between the donors and the ministry, and people coming along with money and it being hard to say no to, people coming along with a cost effectiveness study and it being hard to say we'll drop something. So there's a tendency to just be receptive to adding a new idea but not dropping an old idea, even if it's ineffective or cost inefficient. And there's this need for advocacy in that one of the things policymakers are telling us is they're pissed off with time and again projects come, divert everything, then go, and there's nothing left. And there's no plan for the longer term vision, and there's no trust that if we give the money for it to be handled within a big umbrella, it will be done effectively. So a kind of bottom-up approach of advocacy and a top-down approach that's combined with capacity development and capacity strengthening. Because like with devolved counties, unless you've got the data and the evidence, then it's hard to put something into your budget, your annual budget cycle, and ensure it's integrated into the system. So it's a really good question, and the answer's complicated. I'm sure you'll be surprised to hear.